Good
Okay,
afternoon,
ahead,
everyone. My name is Dr. Tankeu. I'm here today for the presentation of the pain management and recognition of the sign of substance use disorder. I would like to give credit to Dr. Eric Lam, the previous pain fellow, who helped me put these slides together under the supervision of Dr. Joseph Mouhanna, who is the program director for pain medicine, and Dr. David Leszkowitz, who is a DIO and the GME director. The key objective and overview of this presentation is to provide additional guidance and example for the pain medicine milestone, providing therapeutic approach in treating patients with pain. And at the end, understand the factor as is related to pain medicine, as understanding factor of addiction as related to pain medicine. So what is the definition of pain? Pain is a very unpleasant sensation. It can be sensory, emotional, associated with actual or potential tissue damage. The pain is very subjective because we receive information from the patient, and therefore we just have to be attentive on understanding the dynamic and the pathophysiology underlying the patient experience of pain, as because it's self-reported. The fundamental principle of pain management approach on the sixth avenue. The first avenue is that the pain cannot be separate from the patient mental state, environmental and cultural background. Every patient is different, so the way you approach the therapy for each patient should relate on all those factors in order to understand how the patient experience and present the pain. The second, the pain is very complex, so you cannot pinpoint sometimes one area or one attitude in which the patient has a pain. So you need, therefore, a structural way to assess the patient pain that fits the model and take into consideration the different factors. And third, you have to assess the pain with a proper documentation. Once you assess all those three, once you build those three map, you move on the next step. Once you assess it, you did a differential diagnosis. Your question is, should I start with non-pharmaceutical therapy, non-pharmaceutical treatment, or pharmaceutical treatment? Sometimes you can start with one, the non-pharmaceutical or the pharmaceutical. Other option is to combine both of them to optimize the therapy. While you're doing that, you have to be aware of the adverse effects or the interaction between the therapy that you provide and the ongoing treatment that the patient is receiving. And at the end, if for some kind of acute on chronic or chronic, the patient seem not to have a relief, you may add additional element that support the step that you want to take forward, whether it's a procedural step with pain medicine or a surgical step with neurosurgeon or other type of surgery. And therefore, you classify the pain at three type of classification. We have acute pain, we have acute on chronic, and then we have a chronic pain. And we're going to detail each of them. The acute pain is a pain that presents with a clear cause. We can have multiple factors that create or that precede the acute pain. And the pain normally lasts less than 6 months. And those have a physiological and physical factor exam that you can assess with. For example, increase of blood pressure, heart rate. And sometimes the non-verbal signs of the patient are critical to understand the level and the perception of the pain that the patient receives. And then we have chronic pain. In between, we have acute and chronic. We're going to talk about that a little bit further. Chronic pain is a pain that is persistent and recurrent. You can have an acute pain, you solve it, it goes away. And then the same pain come back again, and then you treat it, goes away. And then sometimes it come back, it doesn't go anymore. It depends. So that's the type of pain. Or it lasts more than 6 months. And it serves no useful purpose when you change and adjust. And sometimes it affects the patient quality of life, because the pain is very difficult to predict. And compared to acute pain, where you can have observable sign or behavioral sign, in chronic pain, unless it's very debilitating, sometimes you don't perceive those type of two signs that come with acute pain. And then we have classification of pain based on the physiology. The physiology, we have nociceptive pain, that is a response, that is pain responding to a specific stimuli or tissue injury or specific assault to bones. And we have neuropathic pain is a pain that is caused by primary lesion that induce the somatosensory process to react to that pain. Most of those pain are pretty chronic, like diabetic peripheral neuropathy. And we have inflammatory pain. It's due to activation of nociceptive receptor and sometimes neuropathic paths who create a tissue inflammation. And then when you have nociceptive pain and neuropathic pain, you have to make a difference. You have to understand what are nociceptive pain and what are neuropathic pain. How do you address it? How do you understand it? And how do you go about the therapy on that? What we can remember here is that the duration of nociceptive pain is generally less than three months. So we can assimilate it to acute pain, but it doesn't mean that it's necessarily acute, but the duration can be less than 3 months in general. And for the neuropathic pain, the duration lasts at least 3 months. And the cause of nociceptive pain, like I say, is very identifiable. It's a specific one or multiple specific causes that create the nociceptive pain, compared to the neuropathic pain that is subsequently to a clinical condition that may have arisen while the patient was on a specific therapy or a specific diagnosis. For example, again, is diabetes. I will bring a lot about the example of diabetes, because kind of picture the idea of neuropathic pain. It can be many reasons also. It can be a pinched nerve, but diabetic neuropathy gives us a better understanding of what is neuropathic pain can be seen. And the management also for nociceptive pain, you can combine the non-pharmaceutical treatment and the pharmaceutical treatment. Whether you start with, change of positioning, if it's something about the sprain or something, or you can give topical treatment, and then you can move to a PO, and then later on to the high levels, which are opioid. Compared to the nociceptive pain, neuropathic pain doesn't usually respond to those type of therapy. And we're going to discuss the different type of therapy that you can bring in on top of providing the therapy that you give for nociceptive pain to patients with neuropathic pain, including some intervention that we do in interventional pain medicine. So this also is the same. It just gives you the specific example of nociceptive pain as it affects the nervous, the peripheral, the nervous, the noxious or the peripheral stimuli, compared to the inflammatory pain, the neuropathic pain, their mechanism. And as I said before, we have a acute pain and we have a chronic pain. In between, patients sometimes have pain. They move from the acute to the chronic situation. So, and between those two situations, there are a lot of mechanism, physiology mechanism, emotional attitude that affects the change. And this can be transient, sustained when it starts to be transient, and it moves to be a sustainable pain and a sustainable assault or sustainable reaction, and therefore ends up to being a chronic pain. And this is also all the elements that enter into consideration of transitioning, experiencing a transition from acute to chronic pain. Now you have to assess the pain. You see the patient, you have to figure out how you go about deciding how to treat the patient, or what is the pain that the patient is experiencing, and what are the differentials that you have. And it's key because it provides you the different tools necessary to make a good differential and finally get a clinical diagnosis. Some of the information to assess a pain is the location of the pain, the intensity of the pain, the onset of the pain. Is that a new pain? Is it an old pain that just coming back? The sensory quality of the pain, and also the visual analog. Is it between 1 to 10? And sometimes the patient cannot really describe the pain. Therefore, you use this visual tool to provide an idea to the patient on how they can assess the pain and provide you additional information to make your differential diagnosis. And again, this is a step when you see the patient and discuss with the patient about the HPI history to get the information, the step that you take to move forward as you clear different type of diagnosis that may arise from the information that the patient provides you. So the pain reassessment, so once you've done that, if it's in a hospital, in general, it's advisable to reassess the patient every 8 hours to find out if what you did as an assessment, what you provide as an initial therapy is working. So, and then that's a good way to do it. After you gave them whatever medication or after you decide which therapy is best for the patient. It can be, as I say, it can be subcutaneous, it can be PO, it can be IM, or it can be IV, depending. If the patient is on PO, in general, 8 hours, but if it's an IV, 15 minutes after administration, you have to reassess. If it's a IM, you have to reassess 1 hour after administration. And then you have this question as an option. Ask regularly, if the patient comes with a knee pain, subsequently to a knee replacement surgery in a hospital, you have to ask consistently, because once you divert from the question, you distract the patient from presenting the condition the way they experience and they feel it. So you ask regularly, assess systematically, use a standard rating. Don't change the rating as you come to discuss with the patient. Believe what the patient tells you. Sometimes it's difficult, especially for me as a pain doctor and as primary care provider. Sometimes we are skeptical about the information that the patient gives us. But it's also important to understand that it's the patient who is experiencing the pain. So we have to be aware of it. Choose the best treatment option and deliver the intervention as coordinated. If you have an orthopedic who providing some pain medicine for a few days, you shouldn't come and add more. You have to be aware. You have to be aware of what was provided, what is being provided to the patient before deciding to step on or to step down based on the interaction with the patient and the team that you work with. And you have to, each step before changing any therapy for the patient with pain, you have to evaluate what was given, if it's working, why it's not working, and move forward with the next steps. So this is the most common misconception that we have with pain. The pain is part of our life. Sometimes the patient, we are the doctor, we sometimes also mistakenly say that to the patient. The pain is just part of our life. The patient will say, I just need to live with the pain. It's not necessarily true, okay? And I shouldn't take pain. Some patients will say, no, I don't want pain medication because it's going to make me addict. I won't want to take it. That's also a misconception because it can be addressed. And I don't want to become, an addict. I don't want to get constipated, because some of the pain medication can create constipation. So this is where you have to clear those misconceptions with dialogue, with discussion, with presentation of the facts, So that's what is on this. And you have to also notice when the patient is in the hospital or when the patient comes to see a physician, they have non-verbal attitude who tell sometimes enough or if not as much as what they tell you verbally. And you have to be aware of that. You have to observe. You have to take into consideration the vital that you receive. You have to understand and try to get the baseline of where the patient stands for. And then you have to also sometimes those situations interacted within the family. That's one letter we're going to discuss about addiction, because you have to understand where the patient's standpoint in the family history, were the people taking pain medicine, was the people family complaining of pain or someone in the family experiencing pain. Understand the different type of pain situation. Is it the pain on the bone, the pain on the muscle, or bone and muscle combined together? Is the pain subsequently due to a failed therapy, like for example, neurosurgery, fell back, we call it fell back syndrome. So the patient has a surgery and it didn't went well, and then he start having pain. So all those elements will give you an idea about how the current status of the patient can be addressed while taking into consideration not to put the patient in a situation where he become addicted or he become hooked to the medicine. So and then the barrier, and like I says, doing that is the ideal world. There are a lot of obstacles that need to be overcome to be able to provide quality of care to patients. One of them is the patient. Some patients come by themselves and they come with the family. If you go in the pain clinic, you will see some people, they always come two. There's a parent with a family member, a friend with another friend. So those people can have an influence on how the patient presents the symptom. And also our own attitude as a healthcare provider can be enabling the patient regarding specific therapy or referring the patient to present the condition the way it should be presented. And also the healthcare system, you have to go to a primary care, get a referral before coming to a specialist. If you come to the hospital, the primary care may be reluctant to put the pain medicine, and then they have to call the pain doctor to come. All these type of system create, a barrier to providing appropriate therapy. And also regulatory therapy, regulatory concern. You know, now people are very skeptical on prescribing specific type of opioid medication because it's very scrutinized and you don't know if the patient is taking it or probably taking it. So we're going to discuss later on how we can approach those elements to make sure that the therapy that we provide fits the need of the patient and address our concern about misuse or abuse of the medicine. So, and then that's also barrier to assessment. There's a belief that the pain is inevitable. There's a negative experience with pain. There's a fear of distracting the healthcare team from treating the primary condition. There's a belief that the pain cannot be managed. There's a negative attitude about pain. And also, you know, the adverse effect of the pain medicine that some patients experience. And now, once you have that in mind, it comes time to provide the therapy. You have your own goal as a clinician and the patient has his own goal as a patient. So the patient expectation and the care that you provide at some point based on the clinical condition should find a middle ground where you address the patient issue without overdo it or underdo it. And so that's what it is. As our goal as clinician, are we trying to get the patient get rid of pain, or are we trying to maintain the quality of life? You know, because pain is very debilitating, especially patients with chronic pain. Is very debilitating for their life. It decreases the activity of daily living. It decreases their mobility. You know, and then we as a physician, we may not perceive it that way. So we have to discuss with the patient and try to address it in a way that, you know, provide the optimum care to the patient. So the good thing is, even though we have those barriers, we have a patient expectation and we have our own goal, it's better to start addressing pain concern earlier. You know, we always see patients in our clinic or sometimes in the hospital who come after the pain has been on them for so long that, you know, the earlier intervention will have prevent the current condition to happen. So addressing the situation like any other medical condition, tackling the problem before it happens or before it gets worse is way better. It's the optimal of providing care. So, and then therefore, by doing that, you prevent overdose, you prevent addiction, you prevent dependence by addressing the condition earlier, regardless of whether it's pain, as we're talking now, or any other medical condition. So this is also good. And how do you measure how successful the treatment has been? Is understanding the pain through the eye of the patient. You know, the patient is the one who is experiencing pain. We don't experience pain. We may have a physiologic or pathophysiologic or clinical understanding of the pain, but we don't physically and emotionally bear the pain. Once we kind of link our perception to the real reality of the patient experiencing the pain, then we can kind of find a common ground to provide care to the patient. It's very difficult at some point. And then you take time to do the comprehensive assessment that we discussed earlier. You get a better history. You also look at the previous treatment, if the patient was already on treatment. And then you also look at the psychosocial factor that affect the patient's current condition. And then you look at the comorbidity that the patient may have, who can, you know, make the pain, who can distort the perception of the pain from the patient. And also the past pain medical history. All these elements can give you an idea on how to approach the treatment that you provide to the patient. And you have to engage the patient on his own treatment. It's important to provide therapy to the patient, but it's very critical to have the patient involved in the therapy that you provide to him, because once you do that, you have a certainty that the patient will follow through the therapy that you are offering to him to address his issue. And once you decide to prescribe pain medicine, that's what I learned since I've been in pain, is you always start with a lower dose. Even when I was doing my residency, that's what our preceptor or faculty will already tell us. Always start with the lower dose. Why? Because you can increase the dose. The problem with the high dose is when it's high and the patient has a problem, you have to find, you know, something else to block the efficacy of the high dose. With the lower dose, you can build it up as you go. Okay, start with the simplest. You know, there's a lot of new medication that comes in the market every day, and then there's a new gadget, there's a new type of therapy. Start with what is known to be successful. It may not be the best at that time, but it can provide a step on which you can build additional therapy for the patient. And schedule a long-lasting pain medication if the patient is on chronic, and track the breakthrough with medication. For example, if the patient is on chronic, in this case, we talk most of the chronic patient, you provide them a long-lasting medication, and then you give them additional medicine for the breakthrough of the pain when those situations occur. So like I was explaining before, there's a different type of medication that comes along. For acute pain, there's a different type of drugs. There's a different type of device for intervention. We have to go, like I said, with the simplest. And then, therefore, we're going to start addressing this issue by what is most common known about those medications out there, and how can we use them to provide better treatment or optimum treatment to the patient. So first of all, it's very well known, we use the NSAID. The NSAID it's an early stage. You can have it pretty easy. The patient can well tolerate it, given that you have to be aware of the comorbidity that the patient may have, the co-occurrence with other drugs, the risk of bleeding, and the risk, you have to take all that in consideration. It's always good to start with the simple one, with the NSAID. And these are the description of the NSAID, the pathophysiology, what are they doing specifically, what are the approach when you take them. I always say to people when I see them coming to the clinic with knee pain or in primary care, if you have a knee pain, after the imaging, let's give you a diclofenac. They say, no, it's over the counter, it's not a. I say, no, it's going to provide you some relief, and then we'll see how we go. No, I want this one. No, let's start from the beginning. Let's not start with the addictive medicine. And then you can move to, this is the highest end. Let's go to the opioid when it's come to pain. The opioid medicine block 3 receptors. It binds to 3 receptors, the mu, the delta, and the kappa. This medicine, because of the addiction potential of it, the dependency of it, everybody is concerned about it. Everybody is not afraid, but is wondering if the patient is taking it properly, or if the patient is following what you present to them, giving those medication. And because he's also worked in the brain process, he have that sensation of addiction or dependency. So we have to be very cautious about providing, especially for acute pain. I see patients here who come for knee replacement or hip replacement, and then after we give them some medicine, they say, no, can I have 1 month? No, you can have 1 month. Have you ever been on that medicine? They say, no, we're going to give you like 5 to 7 days, and then you can follow up with your pain doctor, or you can even follow up with your primary care doctor so that they can take from there. The hospital is not there to provide you 1 month supply for pain medicine. And then we have anticonvulsant medication for the treatment of neuropathic pain. So the 2 initial one, the NSAID and the opioids, normally is for the nociceptive pain and some chronic nociceptive pain that the patient may have. For the neuropathic pain, we look at anticonvulsant. We have a variety of them because they act on different type of stimuli. With paresthesia, dysphagia, they have a different approach of pain hypersensitivity. You have a different approach on the peripheral mechanism in the nerve, the sensitization of the nerve. So all of that give us a direction or a clue on how to address the neuropathic pain. So, and then we can go to different level of pain. The neuropathic pain can be, post-operative neuralgia. You can have diabetic peripheral neuropathy. You may have spinal radiculopathy, what we call sometimes sciatica. You can also have trigeminal neuralgia, and people doesn't sometimes know it. You can have HIV-related neuropathic pain stage. We see in one of our clinic a lot of patients with HIV who have those kind of neuropathic pain. So the first line of treatment, as a lot of you may know, is to give gabapentin. And then some of the patients, we go to the lidocaine patch, and then we can move as we move forward to opioid, TCA, and tramadol. But We also have to assess the patient on what they used before that works for them and what they haven't used before, and they may not be so inclined to try it. So this is the medication for, like I explained, the neuropathic pain. Gabapentin, you know, we give it and we titrate. We always say to our patient in our office, and it should be the case, we titrate from 3 times, we titrate from 1 time a day as you build up, but the optimum efficacy is when it's take 3 times a day, depending on each patient. If the patient is very naive, it's likely that with the minimal dose 3 times a day, it will work. If the patient is already on multiple different type of medication, we have to titrate it as you go with the patient. And sometimes the patient come, they're already taking the medication, and then you just have to make sure that the current dosage and the current pace as they take the medication is working. So that's what we understand about titration. And for gabapentin, we have a side effect like somnolence and dizziness, you know, and you can escalate the dose based on those side effects. You know, if the patient is tolerable to that, if the patient took properly with those medication, with that medication, you can escalate the dose. We have pregabalin, is like a sister to gabapentin. Compared to gabapentin, this one GABA is also a control, but this one is a control. We approve. So you have to, sometimes the insurance don't like it because it's pretty new, it's expensive. So it provides also a good relief to patients with neuropathic pain, especially those with diabetic neuropathy and HIV-related neuropathic pain stage. So this is the pathophysiology. I won't go in depth on that. You can get a chance to take it. And also this one, you don't necessarily build it as you build gabapentin. You start with two times administration a day, and then you take it from there as the patient progresses, and you see how the pain evolves. And then you have all the other one, lamotrigine, oxocarbazepine, you have topiramate, you have levetiracetam, you know, all of those is used maybe for other purpose, but it's also part of the therapy of the treatment of the neuropathic pain. And what is crucial, especially for primary care and other specialty like neurology, is that antidepressant can provide pretty good outcome when it comes to neuropathic pain. One of the most famous one that people know now is duloxetine. You know, duloxetine is being used to address depression and diabetic neuropathic pain or any other neuropathy that comes along. I even see them being used to address fibromyalgia. Why? Because it's a component of those pain that we sometimes misunderstand or misdiagnose or take it lightly, which is depression. As I said earlier, the pain is very debilitating. And because it's debilitating, it affects your mental and emotional state. And because it affects your mental and emotional state, it modifies sometimes the receptor of any other factor that affect your well-being as a whole in a society and in a group or as an individual. Therefore, depression, psychosis, and those type of things can happen. So therefore, having a medication like duloxetine will kill 2 birds with 1 stone, you know, kind of addressing the depression symptom or the mood problem while providing relief for the neuropathic pain is a very good element to have. So regardless of what we think, antidepressant can be very useful for those patients. And we have a TCA. It's not used more often now because of the side effect of them. You know, a lot of them has side effect that is detrimental to the patient, and they prefer the new drug. But we have the SSRI, who is typically used for major depression and can provide some relief to some extent to the patient with neuropathic pain. And you know, in the same area, we have the sister of SSRI, it's SNRI, who can provide also treatment. You know, like I was saying, duloxetine is, in fact, is a SNRI who address, you know, fibromyalgia, diabetes, neuropathic pain, while tackling also the depressive disorder. So we should keep that in mind when we have a patient coming to us with a pain, and when we have make the clinical distinction between the nociceptive pain and the neuropathic pain, we should be able to be open to discuss with the patient additional treatment like this one. And also don't forget that, sometimes it's crossover. The patient comes with nociceptive pain. As he progresses, it becomes something change in the life and it becomes a neuropathic pain. Or the patient comes with a nociceptive pain, you address it and then it can cross over each other. The main idea is to find which are the key factor exacerbating the patient's current condition. So also some of those medications, like I said, from different type of therapy can address the pain. We have, for example, medication for insomnia like trazodone, which can also be used for the neuropathic pain. The neuropathic pain is very difficult to pinpoint, to kind of scoop it. So you have to, you don't know what are the other comorbid condition that comes along with the current condition that the patient have complaining of pain. So this is the pharmacotherapy or pharmacophysiology of the medication for insomnia. And I like the topical the most because that's where I like to start. For depending on the patient again, if the patient comes with a broken fracture, you won't give him a topical treatment. You address the broken bone and then you provide some pain relief while being in a hospital. And then you ask the patient to follow with the primary care. But most of the patients that we see sometimes, a lot of patients that we see almost have, a wear and tear problem, osteoarthritis. We have the facet block, spinal cord spinal problems. They have, a joint on joint problem. For those specific type of patients, sometimes they have even muscle spasm and they don't know. They think it's my bone, when in fact it's a muscle spasm that they have. So for those patients, we can provide them, topical lidocaine, topical TSA, topical NSAID. There's a new one, capsaicin. Sorry about that. Is to help the patient with diabetic neuropathy and HIV-related neuropathy pain. We give them to the patient. It's very burning, so it's very particular in a way that you have to give it to the patient. So for some patients, it seems to really very helpful on the diabetic neuropathy pain or HIV neuropathic pain stage. So, and as I said earlier, addressing the pain condition have to take into consideration multi-factor. And you have to embrace sometimes the non-pharmaceutical therapy or the pharmaceutical therapy. You have to be understandable of the patient cultural background and how his background influences the perception of pain and therefore influence the way you approach the therapy for pain. All of that have to be taken into consideration on whether you give non-pharmaceutical or pharmaceutical therapy, whether or not you move forward for the interventional process. If the patient is already on the current therapy but has not felt or do not feel that the current treatment provide him a relief, So, and that's what is described here. You can use the first single modality. You start with a basic pharmaceutical, you do the muscle relaxation, you do physical therapy. Some of them like to go to chiropractor. Then that doesn't improve regardless, and then you're now thinking about intervention. If it's a knee, you can do what we call in our clinic or here in the hospital, the genicular nerve block. So we block the nerve that transmits the signal to the joint to prevent the pain, to prevent the patient to feel the pain. We can do the facet block if it's a radiculopathy, if it's a facet problem in the spinal cord, lumbar or sacral. So we block the nerve, the median branch of the dorsal root ganglion will send a signal to the nerve so that the patient does not have any problem. So we can also do sometimes spinal cord stimulation. If the patient has a failed back surgery and still experiencing pain, this is the type of procedure that you provide to address the issue of the patient. So this is a little bit of pathway as you approach it, and keep in mind that sometimes, and like I said earlier, sometimes the patient have muscle spasm, and also the life change. We know that multiple comorbidity exacerbate the patient current medical condition, poor compliance to a therapy, worsen the patient condition, all of that thing, weight loss, improve the quality of therapy and decrease the exacerbation of the medical condition. So this is how we treat it. Like I was presenting this is how we treat it. You start for acute pain, mostly it's treated with NSAID, opioid, local anesthetic, and sometimes you have splints. You put the splinting, and then you sometimes ice by themselves will address the problem. Or positioning, if the patient have, for example, carpal tunnel syndrome, or you have just a muscle sprain, or you just provide, a positioning change, or a casting or splinting, to address those issues. We don't necessarily go to a PO medication. And the chronic pain is very difficult to treat. Once the patient is on the stage of chronic pain after multiple failed trial, it's very complex to address. It may already be in like 3 medications. Sometimes they are on the NSAID, they are on muscle relaxant, they are on opioid medication. We did some couple of trials that doesn't provide proper relief. And then now you're wondering as a clinician, what is this one, the second step, the third step, and now I'm into procedure, and still the patient doesn't have a relief. And then you start increasing the dose of medication, and then you start being concerned. Oh, I'm giving this patient Oxy 5 4 times a day, or Oxy 10, or hydrocodone only 10 milli 4 times a day. Is it a potential of abuse? Is it a potential of dependence? Is it a potential of addiction? All of the elements come into consideration was tackling the chronic pain, because it's very critical to make sure that you don't fall into that. The problem sometimes is that when the patient comes to you, they're already on those medications for years. So for whatever reason, they decided not to continue the therapy with their previous provider, whether the patient move or the provider move or the provider doesn't want them. You have a new patient who is new to you, but who is very used to all those type of therapy. And then your goal is now to figure out how you can help the patient address the pain, trying to cut down or trying to provide, non-therapeutic avenue to address the patient issue. Sometimes very complex and it takes time. And sometimes the patient doesn't understand what you're trying to do. And therefore, we come to what I was saying, the national epidemic. As we all know, or almost a lot of people know, we have a national epidemic of opioid, of misuse. I don't like to say opioid because there's a lot of other medication that people misuse, not just pain medication. We focus on pain because when we picture the abuse, we picture the abuse with the idea that the patient go to a pain doctor to get the medication. But it's all different type of medication. In fact, all the medication can be abused, can be misused. If you use the medication not for the purpose for what it was meant to be, it's an abuse, it's a misuse of that medication. So given that being said, unfortunately, most of the abuse arise with the prescribed medication. We always think that the street medication are the epitome, maybe because we don't have a data about the street medication, but we have a better data about the prescribed medication because we can track who's providing the medication, where is the patient picking up the medication, the frequency of picking up the medication, the frequency of dispensing the medication. All those elements give us a database to better understand how is the medication is being distributed throughout the patient system. So therefore, it seems based on the data that the majority of the misuse of the medication come from prescribed medication. One of them being prescribed by pain, or one of them being prescribed for the purpose of relieving patients from their pain, regardless it's a nociceptive pain or it's a neuropathic pain. One of the other key elements of this, especially in Florida, in South Florida, given the population that we have, is the abuse, the misuse, or the use, the normal use on elderly population. In elderly population, it's very critical for any type of therapy that you provide. Why? Because of the plasma concentration that the patient will maintain the product. If you give the medication to a 50 years old man or 40 years old man compared to 85, 75 years old, it's different. It may be the same dose, but the process of that medication in their system is different. So we have to add a second layer of consciousness when it's come to providing medication for elderly population. And I've seen it. We have patients in our system, here in the hospital, in our different clinics, who come, they're 75, they take some medication for years, and then you have to explain to them that, the side effect may be more prone because of, the change of the pathophysiology, the change of the physiologic dynamic of your body. So, and therefore, it's always good, especially if the patient first start with you, to start with the smallest dose, and build from there. It's always good to start with the smallest dose because you can fix the small, but the big one, you have to find the counter process. And you also have to review the interaction between the drugs. If the patient, most of those patients, they have multiple drugs, so you have to take into consideration the different type of treatment that they're receiving. So these are the factors that you have to be aware of to make sure that the patient doesn't become dependent, or the patient is not in the dependence mode or in the abuse mode. Assess the risk of use abuse, assess the risk of diversion. We have some patients that the pharmacy send us a signal and say, hey, this patient, we think that he's selling the medication to the street. We have to stop it. And then we have to find a way to discuss the issue with the patient. There's other tools that we do that. These are the criteria. These are some of the key that can start giving you a clue about, maybe this thing is not used properly. The risk of misuse, age of the patient, the previous history of abuse, the previous, family history of sexual substance abuse, the history of adolescent use of medication, and the personal patient history, whether it's psychological, emotional, or medical. And the risk of overdose, you have to be aware of it. As on the previous slides, I was telling that the pain, sometimes the pain, most of the time, the pain doesn't come by itself, especially when it's chronic. It's very debilitating. Because it's very debilitating, it affects the mood, the mental status, and it creates, patient can be depressed, patient can be drug seeking because of trying to relieve the pain. And, all those elements have to come into consideration. And between 18 to 45 and also above 65, we sometimes say, oh no, this person is elderly, he won't misuse the drug that we give him. No, we have patients coming to the clinic, we give them, if they've been on opioid, and then suddenly we give them the urine, and then the urine doesn't come back positive. And then, or it come back positive with just a small level of metabolic of the product that you receive. If you take 3 times a day, we should have in 1,000. If you have it in 100 or less than 100, there should be a reason for why it's just that low, so. And then we have the data to monitor. For example, if I'm a physician, I provide the opioid or a controlled substance. If the patient leaves for my practice to come to you, you should be able to track that patient and make sure that you are not doubling on what I'm giving. You go to eForce, and then you put the patient name, date of birth, and it gives you what was the last time the patient received the medication, what is the quantity the patient received, and what was that supposed to? Was it for 3 times, 2 times a day? Is the time, and that's the first barrier when you decide to prescribe the medication, the controlled substance to the patient, to prevent the abuse, the dependence, and the addiction. The second barrier is sometimes when we send the medication to the patient, the pharmacy can hold on to it. For example, if you give the patient, for example, Percocet for 2 times a day, you give 60 tablets, the patient, and then the patient come maybe on the 20 days to request at the end. Even if you send the script, the pharmacy won't fill the script until the 30 days come. That's a second layer to prevent the patient to abuse it, And then we do the urine drug test to see that the medication that we prescribe to the patient, we can see them in their urine for their metabolite. If they don't see that in the urine, there's a problem. And if you prescribe, for example, opioid, and the person take cocaine, we have a rule when you see cocaine in your urine, first time is a warning. And then the second month, if you come again, you have a cocaine or any other substance that shouldn't be taken while you're taking the medication in your urine, we just stop giving you the medication. We just say, hey, we cannot do that anymore. You cannot be on the medication. We're going to provide you 1 month supply, give you the time to find another provider, but we will not provide you this pain medication while you're still on this substance. So that's the different layer that we put to prevent addiction, because the problem is once sometimes it's addicted, and I think in 2 weeks from now, we're going to have a lecture on addiction. It's very difficult to remove people from addiction. It's very challenging. Sometimes we think it's challenging for us, but it's also challenging for the patient and their family, especially to the patient, if they want to get out of the addiction. Because it's like you hook up to something that you want to give up, but it's pull you back. So it's better to prevent them to be addicted than to try and address them when they're already addicted. because therefore the work becomes twice, 3 times, 4 times, 5th time what you should have done to prevent them to become addicted. So it's very critical, and Dr. Leszkowitz, for being an addictologist for a long time, probably know that it's always better to prevent the patient to fall into the trap of being addicted for regardless of what type of medication, than to remove them from the medication, because it's a long step process. And sometimes they fail as they move forward the pathway, and you have to be persistent and patient enough to kind of help them understand the benefit of being away from the medication that is taking. So that's what I was telling about the database and the doctor shopping to check. And these are the data that we have on the source of prescription from the National Survey database. You can see where the prescription and all the other medication come from, And then these are the data that I was talking about, just to go to the slide, as we did a systemic review of 30 studies to discuss, to kind of analyze all the data that we received. And then this is also a good information that we have, especially when we open the E-force. We don't sometimes, we just open to see the patient take the medication, but there are additional information on the E-force that can give you a clue about how the patient is handling his medication. And if his patient is taking multiple other medication, that is not necessarily opioid related or addicted related to other type of medication provided by another provider for a specific type of therapy. And you can see there's an interaction between those medications, so that you can adjust your therapy based on what the patient is already receiving. So what will we take as a message to our house as a clinician? The pain is best treated with combination of non-pharmaceutical and pharmaceutical therapy. The pain is complex, and you have to do a proper assessment and have a better view, better picture of how you want to approach it, taking into consideration the patient's experience of pain. And then the pain is also multi-influential, so it affects a lot of dynamic, cognitive, affective, social, cultural, and spiritual dimension. And then the pain treatment can be reassessed, can be optimized, well reassessed all the time. In our clinic, we sometimes ask the patient to come every month to discuss and see how we can see how far they come along and how far they are moving forward, given the therapy, or if you have to decrease the medication. And you also have to consider the preference of the patient. While considering the preference of the patient, you have to make sure that you take into account all the other factors, the affective, the cognitive, the social, cultural factor. Because there are some patients who will tell you, I just want this medication, but you don't see the purpose of it. You say, my doctor used to give me that. That's not what he meant. It's not because the doctor used to give you that we have to give you that. And recognize that there is a pain specialist and the resources there to provide the therapy. So thank you so much for your time and your attention. We are open to questions if there were any questions.